Getting pancreatic cancer was not on my radar screen. I knew that it was one of the cancers that you didn't want to hear you had. Someone has to be the percentage that makes it, so why not us? And fortunately, I am one of those people that made a 5-year level. I'm proud to say that I am now celebrating my 6-year anniversary, and I'm in remission.
John is one of my favorite patients of all time, and it's been incredible being with him for over a half decade. And I think it's easy to take for granted how remarkable a story his is, the fact that he's doing so great with no evidence of any active cancer. At that time, we were studying a regimen to get more people to the operating room and get their cancers out, studying this combination of FOLFIRINOX with a blood pressure medication called Lustgarten. We're still waiting for the final readout of that trial. Now, John successfully underwent this treatment with the FOLFIRINOX and Lustgarten, followed by a short course of radiation, and had his tumor out. But unfortunately, within a year, his cancer came back in the liver. And around that time, we had started doing some work showing that we could get rid of the tumors in the liver, and there was a possibility of long-term survivorship. So with that in mind, I treated his liver tumor with high-dose radiation with a technique called SBRT, and that liver tumor disappeared, and he went on a maintenance regimen of gemcitabine and nab-paclitaxel for a few months, did well with that, and then after he was on that for a few months, he went on a chemotherapy holiday. And he did well for quite some time. During that time, his tumor markers started to go up again, so he decided to take some oral chemotherapy, a drug called capecitabine, which is just oral 5-FU. But after a few years, we finally did see the tumor in the liver again, and we had that tumor surgically removed, laparoscopically, and that was about 2 years ago now, and he has remained off treatment, and he's remained without any recurrence. I could not be happier for John. I'm thrilled that he is doing so well. It's been a real privilege to be part of his incredible journey. But my hopes are that we will have more patients in the future who can benefit from these types of approaches the way John did. And working with the Lustgarten Foundation, I'm confident that we will have more successes.
Having worked in healthcare, I know how important research is. So the goal has to be find a way to make pancreatic cancer detectable at an early stage, treatable so that people who get this diagnosis can live long lives. For us, it was natural to look for those organizations that can help me, but more importantly, those that come after me. And Lustgarten is that organization. When I was first diagnosed, there was a 7% chance to make it 5 years. Today, it's 13%. And my doctors are saying to me that it's beginning to feel like it used to when the tide turned for lung cancer, breast cancer, and colon cancer. So if more people like me can be long-term survivors, then maybe one day we can say, you may not get the diagnosis you want to hear, but it's curable.
Good morning, everyone. I'm Linda Tintawi, CEO of the Lustgarten Foundation, and we're thrilled that you are all joining us today. I hope you enjoyed that video. I actually spoke with John over the Thanksgiving holiday, and this spring he'll be celebrating his 7-year cancer-free or cancer journey, and he remains very well, so well that he and his wife are planning a 1-month cruise early this summer. So we are thrilled that John is part of the Lustgarten family and that he continues to do so well. And we're here today to discuss the Foundation's Labs program. For the past 26 years, the Lustgarten Foundation has funded pancreatic cancer research where creative risks yield high rewards to accelerate and expand life-saving treatment options like the treatment that John was able to receive. Our labs program provides long-term funding to promote the development of innovative ideas and speed the pace of discovery by incentivizing interdisciplinary team science in our three focused areas: early detection, new drug development, and personalized medicine. The program includes groups with complementary expertise across the pipeline, from target discovery and validation to preclinical development and clinical testing. Today, you'll hear from three of our distinguished labs leaders who advance Lustgarten-funded research. We could not accomplish this without our donors, and so I would like to extend a very special thank you to the Burns Schwartz Family Foundation and the Warren Alpert Foundation for their support of this incredibly important work. I'm also pleased to welcome Novocure today, the Lustgarten Live sponsor. Novocure is a global oncology company striving to extend survival in some of the most aggressive forms of cancer and is proud to join Lustgarten in working to increase awareness and research in pancreatic cancer. So our thanks to Novocure. We have a large audience today, and we welcome you today, and we encourage you to ask your questions by typing them in the chat box below. And now it's my great pleasure to welcome Dr. Andy Rakeman, Lustgarten's Vice President of Research. Good morning, Andy.
Good morning, Linda.
You know, with the Lustgarten Foundation's broad vision and dynamic strategy, each of the institutions participating in the labs program brings unique ideas and strengths to solve the most challenging problems of pancreatic cancer. And I'm really looking forward to hearing from all of today's guests, as I'm sure our audience is. So welcome to you all, and thank you. Andy, take it away.
All right. Thank you so much, Linda. And I'm also very excited for the discussion that we're going to have today. I know I am going to learn something new about what's happening in pancreatic cancer research. I'm sure the audience will today too, but I think we'll also all get a real sense of what's really unique about the labs program and the way we fund research, and what's really unique about the three individuals you're going to hear from today and their passion and their dedication to driving things forward. So as Linda mentioned, our labs program is a funding program, so it's a grant mechanism, but it's a very special grant mechanism that I think is unique, certainly in pancreatic cancer research and maybe in a lot of research across the board. So in the labs program, we identify research leaders who have a real track record of success and a track record of innovation, who are working at institutions where they have access to resources that don't exist in other places and access to new technologies, and then fund them in a way that allows them and challenges them and demands them to take on the hardest problems and the biggest challenges in pancreatic cancer research. And to do that in a way that involves collaboration, it involves risk-taking, and it really remains focused on driving forward towards patient need. And I think as you hear stories from the three labs that we'll hear from today, you'll really see that coming forward. What you'll also see is that each of these labs is a little bit different and takes advantage of the unique resources that they have and the unique talents of the lab members and their leaders. Labs program has been successful. It's helped us to define the genetics of pancreatic cancer. It's helped us to develop animal models and human models of disease to drive research. It's brought new approaches into the clinic, which you'll hear about some of those today. And these are really just the start of the successes that we're coming forward. So without further ado, I will introduce our guests for today, which include Tyler Jacks, who is the Daniel K. Ludwig Scholar and David H. Koch Professor of Biology at the Koch Institute for Integrative Cancer Research at MIT. So thank you for being on, Tyler. We'll also be joined by Reuben Shaw, who is a professor of Molecular and Cellular Biology Laboratory and the William R. Brody Chair at the Salk Institute for Biological Sciences, so joining us from sunny California. And back to Boston for Dr. Brian Wolpin, who is the director of the Hale Family Center for Pancreatic Cancer Research and the Robert T. and Judith B. Hale Chair in Pancreatic Cancer at the Dana-Farber Cancer Institute. So Tyler, Reuben, Brian, thank you so much for joining us today and for being part of this and for helping to teach our supporters and constituents about the exciting work that you're doing and share some of your story. So maybe, and I hope this really is a conversation between the four of us, and we get to dive into what's exciting in pancreas cancer research, where we see the future going and what we'd like to do. But maybe as a chance for each of you to introduce yourselves and talk a little bit about, what you're excited about. So maybe we'll start with you, Tyler, as you've been engaged in with the foundation since its inception for a long time. So I'll give you a chance to say hello, talk a little bit about, what the research that you're doing and what's exciting, but also kind of how you've seen that evolving over time.
Sure. Well, thank you, Andy, and thanks to the Lustgarten for putting this program together. Welcome to everybody who's joining us, including, very importantly, the donors that help the Lustgarten do what it does, including provide very significant funding to our laboratories to allow us to do this work. It's really very, very important. As you said, Andy, I've been with the Lustgarten for a long time. I think the first meeting that I attended that Lustgarten organized was more than 20 years ago. And the field has changed radically in that amount of time. Honestly speaking, back then we knew rather little about the disease and how to control it. And the statistics sort of spoke for themselves. The outlooks for patients were not good. And I would attribute that to this real lack of understanding of the disease state. Over the last 20 years, through the contributions of lots of people, we've understood a great deal more. And now we understand the disease in sort of exquisite molecular detail. And that's allowed us to identify targets for therapy that have entered the clinic and are showing promising results. And we can envision much more to come. We're going to talk, I'm sure, today about KRAS targeted drugs and how they're faring in the clinic to date and what we anticipate might happen in the future. I think we'll talk about immunological approaches, including cancer vaccines and other forms of immunotherapy that are looking very promising. Honestly, we couldn't have imagined doing that when we began 20 plus years ago, but this is now upon us and it's having impact. I think the labs program is a tremendous vehicle for supporting research. I know in my own lab, it allows us to have a concentration of effort in pancreas cancer with a group of talented trainees and technicians working exclusively on the disease. And we're also, as you said, Andy, inspired to look at the hard problems, not just incremental advances, but really shooting for transformative changes. That you can't do with conventional funding. It's something we can do with this kind of funding. And I think the last thing I would say, Andy, and then I'll open it up for my colleagues, is that you've inspired us to be collaborative. And every project that we work on is a collaboration with other labs. Every project involves pancreas cancer researchers and researchers who weren't otherwise doing pancreas cancer previously. Because honestly, in today's science, we can't do it alone. We have to work well together, and we can go further by doing so. So that's been another great advantage of this program.
Thank you, Tyler. And I'm sure that theme of collaboration is something we'll come back again and again to, because it is such a key aspect of what we do, and especially the labs program. And maybe on that theme, I'll let you introduce yourself, Brian, as on this call, the only clinician here. You're usually not the only clinician in the room when we talk, but talk a little bit about the work that you do, and especially at Dana-Farber, the unique abilities you have to collaborate back and forth between the clinic and the lab, and how the setup is really unique in the Hale Center.
Great. Thanks, Andy. Also, thank you to Linda and to the Lustgarten Foundation for having me today. I would reiterate what Tyler said, that the labs program has really been instrumental to the development of the science and the clinical trials that we do at Dana-Farber. It really is just incredibly woven into the fabric of who we are. And it really is, I think, the foundation of a lot of the work that we do. As Andy said, I'm a medical oncologist, so I see patients in clinic, primarily patients with pancreatic cancer, and then run a research laboratory where what we do is study pancreatic cancer. And I think the role of the Dana-Farber dedicated lab in particular is to be a group that is constantly going back and forth between learning from our patients and taking the best possible care of patients in the clinic who have pancreatic cancer, and learning from the laboratory how to treat those patients better. And I think, as Tyler had mentioned, and Andy and Linda both said, really the goal is that in a year or 2 years or 3 years from now, we're treating patients better than we are today. They are living longer, they're feeling better, and really we're able to cure more people of the disease. I think the reason we are heading in that direction, and I know, Andy, you said we'll come back to sort of our excitement of where we're headed, is because of the big investment in understanding the biology of the cancer. We really didn't know a lot about pancreatic cancer 15, 20 years ago, but there's been really a huge investment in changing that, really making sure we understand what makes this disease grow, right? Why do these cancer cells grow? Why do they spread? Why do they tend to present late where it's harder to cure? If we understand that fundamental biology of what's driving the cancer, we can then use that science to then treat patients better by interrupting those processes, interrupting the things that make this cancer so aggressive. And I think that's really where a lot of the promise has come from, and why I think the excitement in the field is at the highest level I have ever seen it within the past several years. And that's because the payoff is coming, right? The fact that we invested so much time in understanding the biology of the disease is now starting to lead to changes in the clinic. And we'll talk, I know, Andy, more about that. That's something that at Dana-Farber we can see firsthand as we're treating our patients, trying to give them new options, new therapies that they can receive. We can see directly how that impact is starting to be realized. And the last thing I'll say again to reiterate the collaboration part, it's really critical, right? This is such a complicated disease. No one lab can figure this out. No one institution can figure this out. And the labs program has been an absolutely outstanding vehicle to promote that collaboration. We work every day with people in Tyler's lab. We work every day with people in Ruben's group and folks at the Salk Institute. We've taken the science from some of their labs to treat patients at Dana-Farber. This is really, although these labs, quote unquote, are at different institutions, we really see it as one group of people trying to make a difference for patients. So why don't I stop there, Andy? But really just so much excitement for what's to come with these new treatments.
Yeah, no, thanks, Brian. And yeah, the excitement is palpable. And as everyone will hear, the way that the whole pancreas cancer community works together and the way that gets enabled through funding mechanisms like this will become clear to everyone. But Ruben, we'll give you a chance also to say hello. And now, so the Salk Lab is the newest of the Lustgarten Labs programs. So I'll give you a chance to introduce yourself, talk about what's exciting coming out of Salk, but also if you could comment a little bit on, how the team came together there and sort of what's unique about your approach at Salk.
Yeah, great. I want to also thank you, Andy, for this opportunity to speak to everybody. Thanks to Linda and the wonderful Lustgarten Foundation and all of the people who have found Lustgarten for the support that it enables for all of our labs to work together. So my own journey, even to be working in sunny California, started in Boston, where Tyler and Brian are. But the Salk Institute has been a specialized place for certain types of cutting-edge biomedical research, but it's small. It only has 50 professors total, and its focus has always been around people who are experts in different types of biomedical research. And so the exciting thing watching this, starting from myself being a trainee 30 years ago to where it is today, I just couldn't echo more how when I was in graduate school and watching pancreatic cancer and what was known, this was, kind of a dark ages type of cancer for which very little was known. It was mostly just terrifying, the complexities and the inevitability of some of the clinical sequences that would occur. So to see it go from that to the insights that have been gained through, really funding extensively for decades now, different biological insights, and then how that has been able to sync up with clinical treatments. I'm hard pressed. There are only a handful of cancer types that were so deadly and so difficult 20, 25 years ago, for which so much insights have been gained in those years. There are some others that are still unfortunately stuck and have not progressed in the same kind of a way. So the unique thing, as I was alluding to about Salk, is that the different professors on our team have been experts in different kinds of target discovery in different forms of cancer. In fact, only one of the four professors involved in our team have spent their career dedicated to cancer research. The others have been focused around certain kinds of enzymes and certain kinds of genes that go wrong in any disease. And as the years have gone on, they themselves, for both personal reasons and scientific reasons, have gotten more interested, and often with encouragement from both Lustgarten and other people involved in Lustgarten Labs, into dedicating their own teams to pancreatic cancer research. And so this was a really exciting advance in all of our work to be able to contribute to something larger in this way. And so I believe it's been 4 years maybe that we've been a part of this. I would say people at Salk began working on pancreatic cancer about 10 years ago. And piece by piece, as has been alluded to, collaborating and people with completely different kinds of scientific knowledge work together as if we are one super lab dedicated to this topic. And as both Brian and Tyler alluded to, we are in weekly correspondence with our counterparts in Boston, in Baltimore, in every major city across the country in this fight against pancreatic cancer. And that's another difference, I would say, is that this community is really so collaborative and kind of shields together in the fight against pancreatic cancer in ways that you don't always see in other types. So I'll stop there because I know we're going to get more into some of the reasons that it's for so much excitement, both clinically and research wise. But it's great to be here.
Yeah, no, thanks, Ruben. And I will agree, since I came into the pancreatic cancer research field compared to any other field of biology that I've been involved with, it is really the most collaborative. And I think researchers who are really and clinicians who are humbled by the challenge of the disease, and really that's what powers the collaborative approach, really knowing that we need to do better for patients. And certain themes I heard all of you say around collaboration, around the importance of training and bringing up a team. But also everybody mentioned, which I think is really gratifying as a scientist, that how it's really been about understanding the fundamentals of the disease and the fundamental biology that is making a difference and is turning into both, promise for the future, but also improvements in the way we think about and care for pancreas cancer patients today. So maybe, Brian, I'll ask you to put on your clinician hat for a moment, or your stethoscope. And maybe if you could just give some comment of, are there things, tangible progress that's happened that's really changed the way you talk to your patients and the way you treat your patients going forward, and sort of, what is exciting in terms of clinical practice, and then we'll work back into research and what's coming down the pike.
Yeah, sure. Thanks, Andy. So certainly how we treat patients today is substantially different than it was, say, 15 or 20 years ago. I would say the treatments that we have, the chemotherapies, the radiation, which we heard Ted Hong talk about in the video, the surgical techniques, these have all improved, right, over the past 15 to 20 years. And because of that, patients absolutely live longer now than they did before. There are less complications and side effects from the disease now than there was then. And we are curing more patients than we were then today. I think a lot of that progress has been incremental, and I think what we feel like is coming are some real sea shifts in how we do this. I think this understanding of the biology of the disease has now led to some areas where we really want to attack particular biologic processes in the cell, in the pancreatic cancer itself, sometimes in the cancer cell, sometimes in some of the other cells that are part of the tumor, including the immune system. And I think we're starting to see really over, I would say, the past 1 to 2 years, some of the first and clearest evidence that we're going to be able to do that, and that time is not so far away. We talked a little bit, and Tyler mentioned a little bit, the use, if we talk about some specifics, the use of some drugs that try to inhibit KRAS. So KRAS is really the founding mutation of pancreatic cancer. More than 90% of pancreatic cancers have this mutation, and it's really thought to be one of the initiating events that kicks off the growth of pancreatic cancer. We have known for a long time that this seems important, that this gene and this process seems important. But we've learned with a deep understanding of the biology that if you inhibit this protein that is made by the gene, you can treat the cancer. And then this then leads to a host of other changes in the tumor, which can be exploited for therapeutic benefit. What has happened really over the past 5 to 10 years is a lot of progress on the technology side from our chemists and from other scientists to understand how do you now start to inhibit this gene, the KRAS gene. And that is now really coming to fruition. So in the clinic now, we are seeing the translation of all of this science and all this work, all the exceptional work of our chemistry colleagues, now coming to bear with inhibitors that can block the signaling of this gene in the tumor. And we have seen over the past 1 to 2 years some of the first really dramatic responses in the clinic among patients with pancreatic cancer when we block this gene. It is not by any means the end of the road, right? It is a very important first step. We still have more to do, but it really, I think, is the foothold that we've needed. Again, this is the founding mutation of most pancreatic cancer. The ability to block that opens up so many doors for us now about how to bring in additional approaches, whether it is the immune system or whether it is attacking the stroma and the fibroblasts that are supporting this tumor. But it really has been an incredible first step that we have been so eager to see. And then I'll stop, but I'll say there also now are a multitude of other ways to do this. This is by no means the only one, but we've started to see some responses in the clinic to other targeted therapies, to some immunotherapies, things that 5 or 10 years ago I can't say that I had ever seen. And it really does feel like we're on the precipice here of things changing as we now start to get these footholds that we've needed and desperately wanted. And again, just to reiterate, it was based on the biology and understanding that biology and now turning that into practice. I just am so excited to see this happen and for what's going to happen for patients in the future.
Oh, I think you're muted, Tyler.
Sorry. I wanted to follow up briefly. I agree with everything that Brian just said. And just to emphasize a couple of points, because we've all talked about the science and the importance of the science. The drugs that Brian mentioned that some academics are responsible for, but really, to be clear, our colleagues in industry are largely responsible for, so we have to give them the credit. Those drugs were all tested in preclinical models that were created by our labs and demonstrated to be effective there first before they made their way ultimately to these clinical trials. So that's a contribution. Moreover, even more sophisticated models that were generated over time demonstrated actually that if you shut off this KRAS gene in an established tumor, cause it to go from cancer causing to non-functional, it would have a really beneficial effect. And that kind of proved the principle that this was a good plan. If one could have a small molecule drug to do the same thing. So that's an example of where the research led ultimately to this new opportunity. The other thing that Brian mentioned is that this is not the end of the road. There may be patients who have dramatic responses to single agent KRAS inhibition. Brian might talk about that from his clinical experience, but we already know that that won't be true for the majority of patients. They will have a response, but it won't be a curative response. And so we're going to need to do more. And part of the research that's ongoing now is to figure out what else do we need? What do we need to combine KRAS inhibitors with? And I don't think any of us know for sure the answer to that question today, but I'm going to put my chips on the immune system here. And preclinical data from, again, multiple labs have demonstrated that the immune system, under the right circumstances, can see pancreas cancer. Moreover, preclinical data suggests that a combination of RAS inhibition plus stimulating the immune system can be more effective. That has to get worked out still. There's still efforts afoot, but I think that's where we're headed. And I guess the last thing I'll say, because we haven't said it out loud yet, the other thing that's happening in the clinic today are vaccine trials for pancreas cancer, which are showing very interesting effects in disease, in the state of disease where at least resection is possible, where patients can undergo a surgical procedure. Those results coming out of Memorial Sloan Kettering in collaboration with industry and with support from Lustgarten, I should say, are really exciting. And I'm going to predict that it's a combination of those two approaches that will get us closer to the end and maybe even to the end when all is said and done.
And, thanks, Tyler. I think you read my mind a little bit because you brought up some things I was thinking about as Brian was talking, and I'm going to push you a little bit more to go a little bit deeper on some of the things you're working on now, picking up on some of the themes. Brian brought up about talking about needing to get chemists involved to really push things forward. You brought up, Tyler, creation of animal models and genetic models. And I believe actually the way you got started in pancreas cancer research was around in the early days of targeted mouse genetics, employing this, really new and at the time cutting edge novel technology to create interesting kinds of mutations, including KRAS mutations in mouse models that really opened up the field to do new things. You also talked about the immune system now. The immune system is, and the last time we did a webinar like this, we talked with Dr. Bondai, we talked all about immunotherapies. The immune system is complex, it's tough to study, there's a lot of facets. But it's also an area where new technologies are changing what's possible in immunology and identifying antigens for vaccines and what's there. So what I'm getting at here is, could you talk a little bit about how being at a place like MIT, where there's a lot of not only innovation on the biology side, but innovation in the technology side and what's possible, kind of what windows does that open up for you to explore in your lab? And how is that leading to, new kinds of combinations or targets that you then go and get excited and run across the river to talk with Ryan about?
Sure. So I'm happy to sort of fill in the gaps in the history. You're right, Andy. The way it started in my lab was to create a new tool, a mouse that carried a mutation in this gene that we've been talking about, KRAS, and it was a version that we could turn on to its oncogenic or cancer-causing form. That work was done by Dave Tuvison. Many of you online will recognize that name. He's the chief scientist of the Lustgarten Foundation. He's the director of the Cancer Center at the Cold Spring Harbor Labs. He was an oncology fellow at the Dana-Farber at the time and decided to do his research in my lab. And he was motivated to make the particular version of this mouse because of his interest in pancreas cancer. This goes all the way back to the late 1990s, actually. So we built this mouse really with the goal of studying more effectively pancreas cancer. And we used the sort of cutting edge tools in genetic engineering, which we're good at here at MIT, to do that work. That's really allowed the field to use these models, and many of our colleagues do, and to learn the kinds of things that we've been talking about on this call. I'll fast forward to more recent times when another medical oncologist from the Dana-Farber, a guy named Will Friedpaster, who's back at the Farber now, an independent position, works with Brian. He joined the lab to use those models that I was just describing, but to study how the immune system can see and then fail to see a developing tumor. And so he built an even more sophisticated model using even more technically challenging tools and did exactly that, found that indeed the immune system has the capacity to see pancreas cancer, but it basically shuts itself off. And he did a lot of work to identify the molecules responsible for that shut off with the hope that you could inhibit that and allow the immune system to do a better job. And preclinically, in the models that he built, it worked beautifully. We published a paper on that. But really what was in his mind, and Will, as a physician scientist, cares deeply about the disease, sadly has lost his mother to this disease when he was in middle school. So he's motivated on every level. He advanced this concept to the clinic, and Brian might say more about the clinical trial that's ongoing based on that science. It's early days. We don't have the results from the trial, but it's enrolling now. And for all of us who are working in this area, especially those of us who come from the basic science side, it's incredibly satisfying to see our work move from the bench into the clinic with the hope that it will benefit patients.
Thanks, Tyler. And I think that is the story from Will about this immune combination really points to it was not an obvious combination, right? And it really took that in-depth analysis of the changes that happen in the immune system as the disease progresses to point to this. And it's something that we've been very proud of to see it move from a germ of an idea, a kind of risky idea, into something that's now being tested in patients, and we'll hopefully see some results from that coming out in the future. But you know, it's very exciting to watch go forward. And I know, Ruben, it's very much in the ethos of the Salk Institute too, right? Of having deep expertise in the biology and in aspects of the molecular biology to lead to identification of new targets and driving things forward. So again, you know, similar kind of question. What's, you know, how have you used the unique resources at the Salk to dig into some of these questions and to think about treating pancreas cancer differently than we have in the past, and approaching the disease differently?
Yeah, yeah. Thanks, Andy. I think in a way that's very complementary to what we've heard. You know, at Salk, we have these experts in different areas of biology and in different kinds of genes. And as one example of this, a professor here named Ron Evans, who is a leader in the discovery of a certain kind of genes called nuclear receptors that are found in all cells of our bodies and govern all kinds of things. So estrogen even regulates a nuclear receptor, and many even genes that lots of people would be familiar with their names are controlled by this. But as the years have gone on, Dr. Evans turned more and more interest towards cancer, in particular pancreatic cancer. And in an example of how using both animal models and really deeply working on problems over decades, really, not even like one hard year of intense study with a handful of people, really a decade worth of focus in the exact same way from Tyler's lab and from Brian's lab and from others, but with greater models and greater knowledge. They uncovered a rare cell type which had not really been studied or analyzed that carefully, and the realization that one of these nuclear receptors that binds to vitamin D, of all things, so this is a vitamin D receptor. This is a natural part of our bodies that in response to wounds or in response to other type of normal things will help respond to open up scar tissue. This is really, it's a remodeling, not strictly of the tumor cells, actually, of the whole environment, which we call the microenvironment, the tumor microenvironment. And in this case, you can just think of it as the neighborhood around the cancer cells. And what Dr. Evans discovered was that by manipulating this, the function of this gene in the other cells surrounding it, that you could really open up the ability of the pancreatic tumor cells to receive therapies. And even the first time that they had this as a hypothesis, which was based on work that they had done in the liver and actually in the recovery of the liver from injuries and other things. I myself, having worked deeply in cancer and lung cancer and other things for years, was quite skeptical. This seemed pretty far out there in terms of both risk and likelihood that this was going to be able to move the needle in any particular way for this intractable pancreatic cancer. But I think it's an example of how deep focus and deeply studying these things, and then having the expertise in complementary ways. His lab already had the knowledge and knew of existing therapies that were used for completely different kinds of diseases. In fact, one was even used for psoriasis. I mean, this at face value, you'd think this has got absolutely nothing to do with pancreatic cancer. But knowing that and knowing enough and working with chemists to reformulate some of these things, this has led to clinical trials, which Brian has even been a part of, to ask whether or not these types of completely out-of-the-box therapies can actually combine with even existing chemotherapies and any kind of therapy to increase accessibility of cancers. And then I'll add in a classic way that Lustgarten has really helped enable and fuel. If you take that idea to kind of its full extension, we will always be limited as scientists and researchers by what is available in nature or what we can discover about the human body, and then what chemists can unlock. But the other piece of this, which has led to so many advances in medical care, including pancreatic cancer, is engineering, and is the ability to come up with man-made solutions to extend what is naturally possible. And so people in Dr. Evans' lab are collaborating with people in the Cancer Center at MIT, at the Koch Institute, with Dr. Jacks, to come up with novel ways to deliver some of these same agents to extend both the success of unlocking the tumor's ability to respond, and then also to extend the therapeutic window of those responses. So, even again, as an insider, a scientific insider in this space, some of the stories of the experiments they're doing, if you had written this down and passed this on a piece of paper to me in a meeting, like, we're thinking we're going to be doing this in 5 years, I just would have been like, this sounds a little bit like science fiction and wishful thinking. So it's truly an exciting time where a lot of understanding of this disease and previous studies and the limitations of what the existing therapies are right at the cusp of being changed. And that example I gave with Dr. Evans, he's one of 4 or 5 people we have at Salk that are similar gurus of different types of drug targets, which therefore they have used to treat, everything from psoriasis to lung cancer or leukemias, but are now turning that system and really focused on pancreatic cancer due to this commitment from Lustgarten to our team. So that has basically mobilized a team of existing experts to now really train all the guns on pancreatic cancer. And the last piece I'll say is that by this funding mechanism creates another set of opportunities in addition to working with our counterparts around the country. It also enables for infrastructure and for the sharing of very advanced, very expensive technologies that you cannot get funding for through any other kind of mechanism. There's simply no grants. There's no particular way to get funding for these kinds of things. And so with that Lustgarten support, we have created new physical locations within the historic Salk Institute that are dedicated for pancreatic cancer research. And that's a first, actually, even in the history of the Salk Institute, to have something truly modernized and dedicated in that way. So I just want to thank for that, unseen piece of it as well. Literally the construction costs and the other pieces of it to enable this cutting edge laboratory are exciting.
Yeah. Thanks, Ruben. And you did talking about how learning from other diseases and taking what we've learned from other diseases and applying it to pancreas cancer is something I want to come back to. And it is something that people have put questions into the Q&A that we'll come back to. And just as a reminder, folks, feel free to put questions in there or topics you want us to cover more deeply. But I do want to turn, so we've heard now about the KRAS drugs, we've heard about the immunotherapy clinical trial that came out of Wilfried Paster's work, we heard about the vitamin D clinical trial. And I think Tyler made a comment about KRAS that it's not the end of the road. And I think he meant in terms of it's not going to be the last drug that we need for pancreas cancer. But also clinical trials are not the end of the road, right? It's a great goal to get to test things in patients, but we also need to learn from the patients that get enrolled in those studies. So I'm going to give this to you, Brian, to talk a little bit about how we talked about how we go from the bench to the clinic, but how does that process work in reverse too? And how do we learn from our patients to help us to know what's next and where to focus next?
Mm-hmm. Yeah, thank you, Andy. I think that's such an important point, that it is absolutely not a one direction or unidirectional phenomenon, right? We're not only learning about the biology in the lab to then try to help patients in the clinic, although we of course are, but we also then need to learn from the patients who we do treat in a new way. How is the treatment working? Is the way we saw it happening in the lab happening in our patients? If it is happening in our patients like that, how do we then do better with the next study we do where we improve upon what we did in the current clinical trial? I think Ruben and Tyler both talked about science that's going on at the Salk and MIT, both of which directly became clinical trials at Dana-Farber. Right? What the Lustgarten has done with the labs program, again, is set up individual labs at these institutions, but we really see it as one big group of people working together. So at meetings where we're talking about what's going on in Tyler's lab, what's going on in Ruben's lab, where I am at and other of my colleagues from Dana-Farber are also at those meetings, we are constantly thinking, how do we then apply that to our patients? What do we do to bring this to the clinic? Once we do, you're absolutely right, Andy, it doesn't stop there, right? We really then need to understand how are the drugs really working in patients? And now there are multiple examples of that. We can talk about some of those related to KRAS inhibition, but actually both of the studies that came from the research that Tyler was talking about with immunotherapy and the research that Ruben was talking about with nuclear receptor biology, both of those studies at Dana-Farber in patients, we asked patients if they would be willing to give us a part of their tumor before they went on the trial and then while they were receiving the treatment. And the reason we ask them for that is we really do want to understand, once we give the treatment, how does the tumor see that treatment? How is the tumor trying to adapt to that treatment to escape from what we're trying to do, which is kill those tumor cells? If we can understand those mechanisms of adaptation that the tumor tries to use to escape from the therapy we're giving, then the next trial we do, we can try to block those mechanisms of adaptation and do even better. And what I really see, and I'm interested in hearing Tyler and Ruben's thoughts on this too, is now that we are starting to get a foothold with some of these new medications, is how we then run a series of trials, one after the other, over the next several years, where we keep doing this. We push the tumor, we try to kill some of these tumor cells with our therapies, and then we understand how are they trying to escape. And in the next study, we block that escape route and we understand how does that work. And then in the next study, we block the second possible escape route. And really the goal is over the next several years to build a platform of studies where we really make a major impact, right? Where we really help people live a lot longer, not small incremental benefits, but big changes. And we really start to apply these approaches also to cure, right? Where we try to cure more patients. And I think that's really where the learning from the patients then goes back to the lab, and we then do with the next iteration even better than we did with the prior.
Yeah, Andy, let me follow up there. I think that step in the process is so important. And I think we're fortunate that with Lustgarten support and others, you know, but folks online might not know that I serve also as the president of Breakthrough Cancer, which is a foundation that studies various cancer types, including, importantly, pancreas cancer. And in one of the projects that Breakthrough funds, Lustgarten is a key partner in advancing clinical trials for one of the KRAS inhibitors that does exactly what Brian was just talking about, looks deeply when the patient is treated, what happens with all the most sophisticated technical tools that we have at our disposal that we use in the mouse all the time, but aren't used in the patient very often, unfortunately, partly because they're very complicated to use, they're expensive, but they're really important. And that level of investment is critical to understanding in detail what's happening so that we can learn what to do next. I think, Brian, to add to your comment about iterative clinical trials, which I think are critically important, there's a loop here, which goes from the clinic to the preclinical setting where you can test the next concept and then advance it back into the clinic. And so we can rapidly cycle through these concepts and do a better job. Brian didn't use these words, but he implied it. And the patient who was featured in the video at the beginning actually said it himself. Patient as the partner, the patient as playing a key role in the learnings that go on during our ability to control the disease. Partly because I'm sure the patient is motivated to help themselves, but as he said, also to help the next patient. Patient as a partner is critically important. And I think we're starting to use that mindset more effectively in the current approaches that we're taking.
And building on those lines a little bit, and this is going into a bit of another topic, and it's something one of the questions came in about how do we use genomics in the treatment. And one of the things that's different, among many things that's different about pancreas cancer compared to some other cancers where we've been more successful, is we don't have as many tools to individualize treatment per each patient, right? We can't say, well, since you have this set of mutations or a tumor that looks in this way, we're going to give you a different set of drugs. We really haven't had that level of personalization, and some of it is because the genetics are a little bit different in pancreas cancer. It's a little bit simpler. It's not as common, and also, it appears to me we haven't had this depth of understanding of what's different about different tumors and different patients, and the tools in the toolbox to apply them differently. So I don't know if somebody can comment a little bit on, how are we making advances in really trying to understand the uniqueness of each tumor, the heterogeneity or the differences across tumors, and are we at a position yet where we have enough tools to think about personalized approaches for pancreas cancer treatments? Or in the lab, what would be needed to make some progress in that setting?
Andy, maybe I just start with 1 minute, and then I'll turn it over to Tyler and Ruben. I would say for patients today, all patients should be getting 3 things when they come to see me in clinic that is trying to leverage this personalization approach based on genomics, as you're saying. First is that all patients should have their inherited DNA sequenced to try to identify if they inherited a mutation in their DNA from their mom or their dad that may have predisposed them to get pancreatic cancer. A number of studies now at multiple institutions have shown about 10% of patients have actually inherited a mutation from their mom or their dad that may have predisposed them to get pancreatic cancer. We really want to know that. One is because there are some treatments we may use in that circumstance that are different if they've inherited a mutation. And 2, because it does allow us then to offer genetic testing to family members, right? If we find that mutation that they inherited, their family members may also be at risk for pancreatic cancer. And we're not talking as much today about early detection, although that is a big effort of the Lustgarten Foundation and for all of us. But that is a key thing to know if somebody is at higher risk for pancreatic cancer, because there are increasingly data showing that we can screen for this disease among those patients who are at high risk because of their family history and genetic mutation. So that's one. All patients should get their inherited DNA sequenced. 2 is that all patients should have something evaluated called mismatch repair deficiency. And this is a circumstance where part of the machinery that repairs errors in the replication of our DNA doesn't work correctly, and it ends up being many more mutations in the tumor than on average. That happens about 1% of the time in patients with pancreatic cancer. But to go back to things we've talked about before, that is a situation where immune-based therapies, where we try to harness the immune system, work substantially better. So every patient should have that evaluated to find that 1 in 100 that we then would treat differently, okay? And then I would say the third is all patients with pancreatic cancer should have their tumor sequenced to look for mutations that may be driving the tumor. That's how we find if there is a KRAS mutation in the tumor, but there are also other things we find. They are small percentages, Andy, as you were describing, but there are a number of other things that are in the 1 to 2% range in terms of prevalence across patients with pancreatic cancer, where we will treat patients differently. But I think some of the sea change that's coming is that pancreatic cancer is 90% KRAS driven, as both Tyler and Ruben have talked about. So if you know that a KRAS mutation is there, and there are many flavors actually of KRAS mutations, they're not all the same. We want to know which flavor it is. That then opens the door to many more opportunities for this sort of personalized approach, Andy, as you're describing, based on tumor sequencing. So That today is something all patients should have all three of those things done absolutely 100% of the time. All right, now I'll let Tyler and Ruben comment
Yeah.
more.
Completely agree. I'm not a medical doctor, but when I get asked for advice about pancreas cancer or other, I tell them to do exactly what Brian just said. So make sure that those online heard that clearly. You know, the question about genetic heterogeneity comes up also when we think about what happens after you treat with a KRAS inhibitor, for example. How do the tumors evolve? And importantly, one of the ways that they evolve, and we're beginning to learn this now, is that they will acquire some substitute mutation that allows them to survive in the presence of that KRAS inhibitor because they've activated some other pathway, we call it, that substitutes for KRAS. Sometimes we'll have a drug that deals with that, and we can switch the patient to that type of inhibitor. Sometimes we won't, and it will be a little less clear what to do there. But I do also want to mention, and I think this is important as we think to the future, I believe, and the data are starting to show that in addition to those genetic mechanisms of resistance, cancers also adapt through changes in their expression of their genes, not mutations, but what genes get expressed. This is sometimes called epigenetic as opposed to genetic. The state of the cell changes. It shifts from this to that. That's likely to be quite common, actually. And it might be, and again, the preclinical data supports this notion, that if you could target that new state, you could effectively block resistance from arising or deal with the resistance once it has arisen. So I'm actually quite optimistic about that. There's more to be done, to be sure, but the cancers often change, and fortunately in this case, in predictable ways. And if we can get ahead of that therapeutically, we will do a better job.
That's great. I just wanted to add a few words for the people tuning in, to draw an analogy. If you've had, friends or loved ones who've had other forms of cancer, one of the reasons that there's so much excitement right now in the pancreatic cancer field is that for other forms of cancer, such as breast cancer or lung cancer, for example, these common forms of cancer, those cancers start off with the patients having mutations in many more genes. So we told you how pancreatic cancer, 90% of patients have KRAS. In breast cancer, there's no equivalent of a gene that's mutated in 90% of breast cancer. That's not the case. Same thing for lung cancer. In fact, this same gene, KRAS, is mutated commonly in lung cancer, but much more like 30% of the lung cancer patients. And then another 10% of the lung cancer patients have a gene called EGF receptor, EGFR. And so what's also different in the treatment of breast cancer and lung cancer over the past 15 years, which has really improved the outcomes in those diseases, was that scientists came up with medicines specifically against those genetic changes. So they made EGFR inhibitors for that 10% of lung cancer patients that had EGFR mutations. We use tamoxifen for the fraction of breast cancer patients who have alterations in the receptor, for tamoxifen, estrogen receptor. So that knowledge, that personalized medicine approach has in part not been possible for pancreatic cancer previously because 90% of pancreatic cancers are due to changes in the KRAS gene, and scientists and chemists simply did not have a way to target, to therapeutically drug KRAS. So we could watch successes in other forms of cancer treatment, but they simply didn't exist for what was the major genetic driver for pancreatic cancer. Now that for the first time there are therapeutics against KRAS, we now are in a position for pancreatic cancer, such as those other breast cancer or lung cancer were 10 to 20 years ago, in terms of learning about how much targeting that initiating event can put tumors into remission. And then as both Tyler and Brian just mentioned, critically identifying what the first resistance mechanisms will be now that for the first time in history, we have drugs that we can treat 90% of the patients with. How many of those 90% then get changes in this particular gene as a secondary response, or in this epigenetic regulator, and then developing the therapeutics for those. The good news, coming back to what Tyler just said, is that many of the mechanisms of resistance that we can predict that may happen in pancreatic cancer are the same styles of resistant mechanisms that have been seen in lung cancer and in breast cancer to other completely different kinds of therapies. So the cell, our bodies only have a certain number of tricks in tools to try to keep tumor cells alive. And so as a larger scientific cancer research community, we have far more tool compounds and things that, as Brian was alluding to, can be put iteratively into clinical trials today. We are unlikely to have to wait another 30 years for the first new drugs against some of those resistant mechanisms. So that's also a focus at Salk, that we're very keen on using our knowledge of different kinds of drug targets, knowing there's not going to be one magic drug that you add in with KRAS drugs to get that more curative response. We can predict and assume ahead of time that patients' response is going to be varied, and that we will need 4 or 5 different styles of therapies to combine, and we're excited to get that started.
And Ruben, I think you brought it back nicely to where everyone started here, of saying what's exciting right now is we understand enough about the biology to approach treating the disease differently. And that's exactly that point of, we now have drugs that address what's driving the cancer cells rather than just kind of blunt instruments to kill all cells. And I think you really well brought it back to, and maybe if you want to say a little bit more about how, and at the Salk, where you said, we have a group of people with illustrious careers and very established in bringing forward treatments for other diseases and other cancers. They're now turning their attention to pancreas cancer because they see these opportunities coming. And maybe if you want a little bit more comment on how learnings from other cancer types, metabolic diseases, all the various things that your team has been working on, how that's, allowing you to look at this problem from a little bit different perspective and make some other kinds of advances.
Yeah, thanks, Andy. I think that is something a little bit in the DNA of the Salk. Perhaps just because it's small and we've always been forced to be nimble and think outside of the box in these different areas. Also having professors who work in very different spaces, right? Even within the Cancer Center, I'm the director of our NCI designated research cancer center, yet a fraction of my lab has always worked on diabetes. And there are other people in the lab who work on actually Parkinson's. So taking lessons from other diseases and advances of new therapeutics for something that feels extremely different, like Parkinson's, and knowing in great scientific detail about why a particular drug's mechanism of action may be applicable in ways that one wouldn't normally think, but based on deep analysis of how the actual pancreatic cancer patients are responding to their therapies. As Tyler said, thinking of each patient really as a partner, their responses, the trials that are going to begin and have begun, that Brian has begun with, researchers at the Salk with all of their wonderful expertise, that's great, but that doesn't really help unless you have the actual samples and you have actual partnerships with clinicians, and you can deeply study how real patients are responding at 2 months, at 6 months, and dive deeply into all different types of changes, including changes to the metabolism, changes in various amino acid things in our blood, things that can serve as both future biomarkers of response, but also as out of the box targets for therapies. I think that is something that that will be our contribution to the larger Lustgarten teams and to pancreatic cancer research is taking knowledge of different diseases and ways that different classes of enzymes have been targeted over the last couple of decades, and then convincing Brian and Tyler and others that let's take this bet, right? Every scientific plan, every clinical trial is taking the best information we have up to that point in history and making a logical leap, and then testing and asking in real time, how did that fare? And not being wedded to our preconceived notions, right? Being open-minded that something that we thought for sure would be the magic bullet, in fact, is not going to be enough, but something else which seemed foolhardy 2 years ago may actually hold the key to future therapy.
Thanks, Ruben. And so I appreciate people putting the questions in the chat. I think we have some excellent ones here. Maybe we'll run through some of these to get some really directed answers for folks. So one, maybe that Tyler, you'd be the best for these questions around immunotherapies and, you know, risks, safety risks, especially for people who have other immune diseases going on. We mentioned the immune system is complex. It's good and it's bad in almost every situation it works in. So if you could talk a little bit about that and maybe elaborate a little bit more on what's going on with the vaccines and pancreas cancer.
Happy to do that. The question of immunotherapy and autoimmune disease is an important one. I think to start off, I would say autoimmune disease and what we're trying to do with respect to immunotherapy for cancer are sort of the other two sides of the same coin. On the one hand, in cancer, we're trying to stimulate the immune system to eliminate cells of the body. And in autoimmune disease, we're trying to protect the cells of the body from immune attack. So we've actually learned a lot about how to do that for cancer by understanding what we know about autoimmune disease. Some of the drugs that are used in the clinic today for cancer come from the studies of autoimmune disease. From a safety perspective, these therapies can stimulate an autoimmune response. One has to be careful, or one's doctors have to be careful to be on the lookout for that. Fortunately, there are methods to suppress immune responses where you don't want them to occur that can mitigate that. And Brian might want to say more from a clinician's perspective about that. I don't know, Brian, maybe you do, whether one screens out individuals with autoimmune conditions in thinking about using these therapies, but I'll come back to you and ask you that question in a second. With respect to the vaccine trials, there likely are more than what I'm about to say out there ongoing, but I'll just mention one. I mentioned it briefly before. It comes out of Memorial Sloan Kettering, and the principal researcher is Vinod Balachandran. It's work that was funded, as I mentioned, in part from Lustgarten and others, and involves a couple of companies, Genentech and BioNTech. And what they showed in a paper published 2 years ago was that patients who were undergoing surgical resection of their tumors, when given vaccines that were directed against particular alterations individually in their cancers got sequenced, their DNA of their cancers got sequenced, and candidate, we call them antigens, alterations in the DNA, were then used as the targets for these immunotherapies or these vaccines. In this study, it was relatively small. Half the patients showed a vaccine response, so the vaccine did something for half the patients. And in the first paper that was published, those patients who did respond to the vaccine had remarkably longer disease-free survival compared to the group that didn't show a vaccine response. And all of us stood up and took notice to that. That paper was published a couple of years ago. I just heard Vinod Balachandran report longer-term follow-up of those same patients, and the data look almost as good. Now, 3.5 years later, there have been a few recurrences, but I believe 6 out of those 8 patients still have disease-free survival, which is really, again, remarkable. Now, small numbers, still early days, A phase 2 study is being planned. I don't think it's enrolling yet, but certainly being planned. And that larger scale study will be critical to know just how well this works. But I think all of us are feeling a sense of confidence that this strategy of personalized vaccination in the post-surgical setting will add benefit to patients who are in that state of the disease. So that's what I would say about that. But Brian, why don't you talk about whether you think about autoimmune conditions when you think about prescribing cancer immunotherapy?
I think the short answer is yes. That does go into your thinking as you make decisions about what type of immune therapy you may use and whether a patient is likely to have more or less side effects from that therapy. As Tyler mentioned, they are essentially different sides of the same coin, that if you rev up the immune system too much in someone who already has problems with autoimmunity, that can lead to problems. So that's definitely something to review with your physician, the person that you work with in your care, because that does go into decision making about how we do this. And I would reiterate also what Tyler said, that there are now several vaccine studies that are ongoing, including actually the one that Tyler mentioned is now enrolling actually into the phase 2 study. These are all studies that are for patients who have had or can have surgery for their cancer, right? It's at a place where we think that the amount of cancer present is less, giving hopefully more opportunity for the vaccine to be effective. I was in clinic yesterday, actually, and saw a patient who was on one of these studies getting vaccination after his surgery. So I think there is a lot of hope that these will allow us to increase cure rates. We don't know yet. It's definitely too early to say that. We don't know yet, but that is our hope. And some of these, to go sort of full circle back to what we talked about before, are actually vaccines against KRAS itself, meaning the KRAS mutation that we're trying to target with some of the drugs that Ruben and Tyler have been talking about. That actually can be a target for a vaccine. And that actually is what my patient was receiving, was a vaccine to actually look at trying to target KRAS itself. And then one other thing I would say, which I think is a really exciting frontier for us to be thinking about, is how we think about preventing cancer, right? If people are at risk for cancer, we know they're at risk to get pancreatic cancer. We don't want to be passive, right? We want to try to prevent that cancer from ever developing. And some of the first studies funded by the Lustgarten Foundation and initiated at Johns Hopkins have actually been testing that approach, meaning can we use a vaccine targeted to KRAS, again, going back to this driving mutation that is so common in pancreatic cancer, to try to actually prevent a cancer from ever developing. And I think that's equally as important for us to be thinking about, right? Not only treating the cancer once we find it, but how do we prevent the cancer from ever occurring in the first place? And that, again, is part of the Lustgarten strategy that we have all also been involved in, which is very exciting.
Yeah, thank you for bringing that up, Brian. I think it is, it's actually work out of Liz Jaffe, who's our chief medical advisor and runs another one of the labs, who's not on this call. We just have 3 of the 6 of you represented here that's been driving those, and very exciting. And it'll tie into the last of the kind of speed round questions from the Q&A that came through for you, Brian. You talked about somatic sequencing and inherited mutation sequencing. Are those things that are covered by health insurance? Should they be accessible? Is this something that everyone should be able to get, or is it still significant barriers to jump over to get access to those kinds of testing?
So with the US health system, there can sometimes be barriers to coverage, given how different insurance plans can be one patient to the next. What I would say, though, is that these tests, these are blood tests actually, that mostly, although they also can be swabs of the cheek too, you just need a little bit of somebody's DNA that they inherited. These tests are now part of national guidelines for what is recommended to be done for all patients with pancreatic cancer. When these type of tests go into national guidelines that are provided, that usually provides the impetus then for insurance companies to feel comfortable that they need to be covering this. And I would say a lot of the work, again, as we've been discussing, that led to those guidelines was the original research funded by the Lustgarten Foundation. Right? There were multiple studies. One actually came from our group at Dana-Farber. There was another at Johns Hopkins, which, as Andy said, is another site of the dedicated lab program. Another from Sloan Kettering, which Tyler had mentioned related to vaccines. A number of us published papers, relatively short interval time next to each other, that showed these mutations are present. That then led to a sea change where we started to test this in patients, and we realized, yeah, this is really true. This is not what we expected. To some of the things that Ruben said before, we don't always know what we will find, right, when we initiate studies like this. The study we did at Dana-Farber, actually, we were doing more to look at the tumor. We were actually sequencing the tumor, and this was a Lustgarten-funded study, actually. But we wanted to sequence the inherited DNA to understand what was different from the tumor and what was inherited. But we were really focused on the tumor. But as we started to get the inherited DNA, we kept seeing mutations in the inherited DNA that we didn't expect. But we had to say, wait a second, this looks different. We then got another large group of patients at Dana-Farber who agreed to let us sequence their inherited DNA, hundreds and hundreds, and we're able to validate that that really was true. So again, not the original goal of the study, but made us take notice. Several other centers saw the same thing. And then that, now this is about 4 or 5 years old, led to changes in national guidelines. So this should be something that is covered by insurance. It is something we should be pushing for all patients with pancreatic cancer.
And very quickly, and then we'll give everyone a chance to wrap up. If somebody is found to be at high risk because they have family members or they have an inherited mutation, there are programs they could go into for regular checkups and surveillance to see if anything begins to appear in their pancreas, correct? Is that?
Yes, that is right. So many of the major cancer centers around the US now have specialized clinics for patients who are at family risk of pancreatic cancer. And they have specialized doctors who know what that screening should look like and how people should be followed. And some of the first data have become to emerge really only over the past several years that if patients who have this higher risk because of their family history or an inherited mutation undergo screening, which is usually MRI and also an ultrasound, that they are much more likely to be diagnosed with the cancer early. And that has really pushed us to try to get the word out that people who have this family history should come to these specialized clinics. Again, it's not only at Dana-Farber. We, of course, have one, but there are many major centers now around the US that have these clinics. And there is a certain expertise that's required. This is not run-of-the-mill medicine, so it's not so straightforward. There's a lot of judgment that goes into this. They really should go to a specialized clinic to be seen for this.
Thanks, Brian. All right, so we're coming up towards the hour, and I want to make sure I give each of you a couple of 2 minutes, 5 minutes to close out here. And since it is December, we're getting towards holiday season. Two things that always come up for me holiday season is one, the feeling of hope and hopefulness of what's coming next, but also of wish lists. And my kids now, my teenage kids, it's an app that they send me a list with links directly to Amazon or elsewhere. I don't know if we're going to get links to Amazon for our pancreas cancer research wish list, but I'd like to give you each a chance to close out. Just tell us, what makes you hopeful that things are going to be better. I think we're clear that everyone really sees a bright future, but also what is on your wish list to turn that hope into reality. So maybe we started one direction, maybe we'll close the other direction. I'll give you, Ruben, the floor first to kind of give us your view for the future and where we're going here.
Yeah, that's great. Thank you. I guess on my wish list as we wrap up 2024, I'm hoping for, eagerly anticipating some of the clinical trial results that have begun with people like Brian and his team. And for us 12 months from now, being able to see just how much more rapidly we are learning. I mean, it's not going to take a week. It's still going to take many months and a couple of years to fully understand the outcomes of these first wave of KRAS inhibitors and some of the other new therapies. But I think each year, if you look a year from now, 2 years from now, the amount of knowledge we're going to gain in the way of how most pancreatic cancers are treated is about to change. And so I'm most excited about all the wealth of new challenges and new things to test. And my wish list was for Lustgarten to remain a beacon of hope and for funding in this area, and for people to spread the word about pancreatic cancer and Lustgarten and other foundations like it, and how much impact that has. These are truly cases. I can speak again for my own research institute. There are now tens to hundreds of people focused on pancreatic cancer that simply 5 years ago were not. They were focused on other diseases. But due to donations to Lustgarten and due to the focus of the other researchers here, we are now all in on pancreatic cancer. So it's very real. It's very palpable, and there are changes afoot, and we're excited to take on those challenges. Happy holidays to everyone.
Thank you, Ruben. And if your wish list is that Lustgarten is going to remain dedicated and committed and in the game for this, it may not be a click to Amazon, but that's one I'm pretty sure we can make sure is fulfilled in 2025 and beyond. But Brian, I'll give you the floor now.
Sure, thanks. Yeah, I can't wait to send you my app filled out so that you can give all the wishes. So I would probably say two things. One builds on what Ruben said. I really want to see rapid iterative clinical trials that push things forward in a way that is much more dramatic than we've ever seen before. I feel like we're on the cusp of that. I really want to see that happen. I think it requires a dedication to biology and science, like we've talked about, because it's going to have to do this back and forth between the lab and the clinic. And I think Tyler said it perfectly, to partner with patients to do this well, but to do it quickly. Having now done this for almost 20 years, it's been too slow and it's been hard to watch, right? As our patients have suffered from this disease, I really want to see this happen quickly and iteratively in a way we've never been able to do before. So I would say on the treatment side, that's my wish. My other wish, and I could have more, but I'll limit it to two because so Tyler has some times also. But my second one is I really would like to see the advances in technology that are building towards early detection and prevention realized clinically, right? So we've spent a lot of work, a lot of time as a community, as a group, trying to push forward the technology is needed to find these cancers early and to prevent them. We can start to see the first glimmers of these coming to patients. And as is sort of really the main niche and role for the Dana-Farber dedicated lab, we're starting to now push this into the clinic and seeing some of these things happen clinically. I want to see that move forward quickly. I think we really need early detection in addition to better therapy to cure as many patients as we can. And my second wish is really that that happens quickly and we start to see some of these advances in the clinic around detection and prevention. Thanks, Andy. And I'll say the same as Ruben. A happy holidays to everyone. And thanks so much for joining.
And thank you for that, Brian. And I will agree. Early detection has always been a high priority for Lustgarten Foundation. It continues to be one, but it's also one that it feels like we're shifting in where we might have been with therapeutics a few years ago, where technology is shifting. Now it feels not just aspirational, but possible. And people should stay tuned because I think you'll hear a lot more from Lustgarten and other players in this area over the next couple of years around what's going to be possible and how much effort goes into early detection. But Tyler, I'll give you the floor last to let us know where we should be going.
Thank you. Well, I'll start with my happy holidays greetings to all, and thanks to Lustgarten for putting this together and all the support that we here and others have received from this wonderful organization. In terms of hopefulness, I hope we all have told you over the course of the last 90 minutes that we are hopeful, and I think genuinely hopeful, based on the progress that's being made in the laboratories and now in the clinic. You all have probably heard things like this over the last many years and maybe have grown skeptical of such claims. I think it's safe to say that we're in a different place now with the tools that exist and the progress that's been made. So I'm extremely hopeful over the next several years that this disease will be thought of differently and managed differently than has been true. In terms of wishes, I'm really looking forward to some of the data that's coming out of these clinical trials that we all are funding together. Brian's deeply involved with. I think we're going to learn a lot as we look at those data, and I'm really anxious to see what they look like. It'll be the first data set of its kind, actually, to examine deeply what's happening in patients treated with these new drugs. My second wish would be that, like Brian talked about, the iterative cycles in the clinic, we need to be iterative between the clinic and the laboratory much more rapidly. We're in a place now where the trains are on the track, they're ready to roll. That was not true very long ago. When we didn't have what we needed, now we do. And we can't wait around and we can't drift off. We need to be focused. We need to work with a sense of urgency, collaboratively, to get there as fast as we can. So that's a wish for my group and all of our groups, to bring that attitude. And then the last thing I would say, coming to Brian's point and yours about early detection, we haven't mentioned it one time, although Brian works on it, the role of computation and machine learning and artificial intelligence, and how is that set of developments going to change the picture for how we think about pancreas cancer early detection. I expect that it will. I don't know the recipe just yet. Could be imaging, could be biomarkers, could be genomics, could be other. But we need to bring our colleagues from that world more clearly into our world, to bring those very, very powerful tools to help us solve this problem.
Well, Tyler, Brian, Ruben, thank you so much for spending time with us today. It's been great. And I think I know I've learned a lot new. I also feel very hopeful, also feel like we definitely have our work cut out for us, but in a different way than we might have had in the past, where it's not just a daunting task, but a task that is starting to appear to be achievable, and lots of work to do, but we can see the road that we need to travel to get there. And thank you very much for laying out those last hopes and wishes. I think that you will hear a lot more about those in the months and the years to come, as those are all priorities for the foundation as well. So Linda, thank you for joining us back, and I don't know if you want to close us out.
Great. So thank you to our marvelous host, Andy Rakeman, who again is our Vice President of Research. And of course, thank you to our amazing lab leaders, Dr. Shaw, Dr. Wilpin, Dr. Jacks. And I hope what you really heard today was that this type of funding is so important to the labs, and it provides resources that aren't available from any other source. And the collaborative nature of the work is what's really pushing us forward. And obviously you heard everyone's hopes, and you heard, as Dr. Jack said, that we've built the tracks, and now the train is going to be on the tracks, and that is what will continue to push us forward. So thank you all for joining us. Our next Lustgarten Live will be taking place on January 22nd from noon to 1 p.m. Eastern, and it will highlight the advances we have made over the past year, and importantly, what 2025 and beyond holds for advancing pancreatic cancer research. Andy, you'll be joined by our Chief Scientist, Dr. David Tuvison, and our Chief Medical Advisor, Dr. Elizabeth Jaffe. This is always a fascinating discussion. We're really looking forward to it. And for our audience, please watch your emails for details. And until then, we wish you a wonderful and very happy holiday season, and we'll see you all in the new year. Thanks again. Thank you.